I've got Dr. Amalu on the phone, and we are both looking at the same computer screen on a patient that we will call patient number 7. Dr. Amalu is in California. I am in Iowa. He has emailed me these patient files since we are both using the Titron C3000, and I have called him and asked for some help in analyzing these patients. Dr. Amalu is a board-certified clinical thermologist, a diplomat, and a fellow of the International Academy of Clinical Thermology. He's also a member of the American Academy of Medical Infrared Imaging, International Thermographic Society, and the International Academy of Clinical Thermology. More importantly, he has been using a paraspinal C3000 scanner for 10 years in his practice, and in so doing has had a lot of clinical experience in interpreting graphs. And with us tonight, he's going to share some of his experience in taking us through these 3 patients. And Dr. Amalu, you are on the air, and we are looking at our home screen, and I have patient number 7 pulled up.
Okay, Roger. Well, thank you for having me. I'm glad to do this for you. Let's go ahead and take a look at patient 7.
All right.
And we'll go to Scan Utilities, F4. And we've got 2 scans here we're going to look at today. We'll choose any 2 scans, and we'll pick B and A. Now, the 2 graphs that are up before us here, the yellow one, taken 8/17/94, is the patient's established abnormal pattern. You can see by the center graph, the differential, or the delta T, that the swings are large and out well past 1.5 degrees centigrade. What we want to see, of course, as a normal is a very gentle wavering scan, or a very straight one, well within the very 2 first-grade lines, or the 0.5 degree centigrade. That would be very normal. But in reading these scans, what we do when we teach doctors to read these scans is the first thing we need to look at, though, is the DTs, or the direct temperatures, the 2 graphs on the side, the right and left. It's more important when we read these to examine the scan today to the established pattern, the one before, is to look at those DTs and see if they're very similar. If they're not, then the patient's not in pattern, because the DTs tell us where the hot and cold zones are. Let's go ahead and read these scans and kind of get a feel for this. Again, the established pattern is the yellow one. And the new one that we have up here, 9/14/94 in red, is a scan taken the very morning that a patient was in a very severe whiplash car accident. She had been fine before, feeling good. We're going to go over the clinical presentation here a little bit on this patient because it is unique to this scan. The patient was in the waiting room with fairly free movement of the head, very upset because her car was so damaged and it was so new. And again, didn't look too bad, said she did have neck pain. And I brought her in, and we took the scan on her. As you can see, it's not really her pattern. If we look at this carefully and we go over to the left DT, you can see up in the approximately the 10 centimeter level, we have some curves that are similar, but when we get down to about 5 centimeters, we have a problem. It's not the same. Again, on the other side of the graph, at approximately 5 centimeters, you can see it's quite different also. And as it moves up, it's not the same. So we definitely don't have a match. But what's most unique about this scan is right at that 5 centimeter level. We have a swing of the graph line towards the right. Now, on these scans, anything towards the right is hot, and of course, anything towards the left is cold. If we go to the top of the DT windows here, you'll see 30 degrees centigrade on the left and 38 on the right, so it's everything that's warm is towards the right. So basically at 5 centimeters here, we have a warm spot, and if we go over to the corresponding DT on the right, again, another warm spot. Now, basically we have to be cognizant of the fact that the patient could have some muscle spasm here, some damage to the soft tissue because of this accident. That damage could show up later on And in this scan here, what's nice is that it's not readily apparent. Again, both of these scans are fairly cool. The DTs are very close to each other. So when we had the patient not in pain or before, it's basically the same now. So that's a good thing. What's unique about this appearance, this warm zone across roughly the lower 1/3 of the spine here, is that it gives us alarm because it's so focal, it's in one area, and because of this presentation, I suspected a fracture. Even though she was moving around pretty well, she was in discomfort, but there was no apparent alarm that there was something going on. And the first alarm that brought us to this attention is this scan. I know some doctors would say, well, we were going to x-ray the patient only. I mean, we're going to do it anyway, excuse me. Some doctors say, well, I don't x-ray patients. Well, this scan here is enough of an alert with that hot zone right across the spine like that. On a camera, if we were using a thermal camera, it would appear as a fried egg sign, which is pathognomonic for fracture. When we did take x-rays on this patient, she had an anterior wedge compression fracture of C6. And she had x-rays on files before, so that we could absolutely confirm that the accident did cause this. So this is a unique presentation of a fracture.
This is right at the approximately the 5 centimeter.
Right.
And again, this is a cervical graft.
Cervical only scan.
Mm-hmm.
So that was unique to this one. Why don't we go ahead and move on to the second one?
All right. I'll close this down. We'll go to load patient. And what patient would you like now?
I gave you 7.
6 and 4.
Okay, let's go ahead and go to patient number 6. Now we have patient number 6 up. We'll go ahead and go to utilities again.
Mm-hmm.
And now we have a few scans to look at. What we want to take a look at here first, we do have an established pattern on this patient. And what we can do is we can actually we can look at that in a moment. But what's more unique about this particular patient is the full spine. Why don't we go ahead and cover this first? Why don't we go ahead and select 2 scans and select M and K, which is the same day, the patient's pre and post. And
All
let's
right.
bring those up. Now, the yellow scan is the patient's established pattern. We usually take anywhere from 2 to 4 scans of the spine the first day the patient comes in to establish a static pattern. And this patient's pattern is the yellow. And afterwards, in red, is after the patient has been adjusted. And then by looking at the scans here, you can see that we really don't have any other matching thermal deviations in the delta T. The scan in red is fairly straight, and the pattern has been obliterated, so this is basically a very clear scan and a very good resolution of the patient's presenting neuropathophysiology. So this is a good thing. We have a good outcome from the adjustment.